Welcome everyone, and thank you for joining us today for this forum on understanding grief. My name is Farah and I will be your MC. We're here today to explore a topic that is deeply human, yet often difficult to talk about: grief. Grief is something we will all experience in one form or another. It doesn't only follow the loss of a loved one, it can arise from many kinds of change. Loss of health, relationships, identity, or even expectations about how life should be. And while it's universal, grief is also profoundly personal. Understanding grief begins with allowing space for it. It also means acknowledging that grief doesn't need to be fixed. Instead, it asks to be witnessed, supported, and understood with patience and compassion. Today's forum is an opportunity to do just that, to listen, share, and to gain insights on what grief looks like and how we can support ourselves and others. So whether you're here as someone who is grieving, supporting someone else, or simply wanting to understand more, there is much we can learn together. With that, I would like to introduce our first panelist, Dr Mojdeh Bassiri. Dr Bassiri is a trained psychiatrist who completed her medical degree at the University of Western Australia and continued to complete her advanced training with the Royal Australian and New Zealand College of Psychiatrists. After the completion of her specialist training as a psychiatrist, Mojdeh worked in public community mental health and has been in private practice for the past 12 years. Mojdeh's work with patients almost always includes exploring grief alongside addressing other mental health conditions, recognizing the importance of this deeply meaningful aspect of an individual's experience. Outside of work, Mojdeh devotes her time to family and friends, enjoys gardening, reading poetry, and improving her art skills. Please help me in welcoming Dr. Mojdeh Bassiri.
Good afternoon. I'd like to begin by acknowledging the traditional custodians of this land, the Whadjuk Noongar people, and pay my respects to elders past and present. I've been asked to share some of my thoughts on grief. I have less than 30 minutes, which is not long for this important topic. My challenge has been selecting what I've found valuable in understanding grief for myself, but also for my studies and my work. Hopefully something of what I'm about to share with you will help in some small way today. Grief is a given. Each of us have faced loss and grief, and each grief story is unique. As Elizabeth Kubler-Ross has said, our grief is as individual as our lives. I worry that in our modern society, we focus on being happy, fixing our negative emotions. We quickly turn our attention to the positive side, busying ourselves with distractions, and hence we risk making grief a taboo subject, either avoiding it or pathologizing it. Grief is not a disease, it's a necessity. There is no shortcuts. It's not a destination, it's a process. It comes and goes with attention, oscillating to and from the pain. The only way through grief is to grieve. Those around us and those who came before us can have key insights into understanding grief, and we can become experts of our own grief in time. I will start with some definitions, and I want to mainly focus on the grief associated with bereavement. I will then discuss when grief becomes more complicated and how it differs from depression, and the task involved in grief. This is a quote attributed to the late Queen Elizabeth. Grief is a price we pay for love. When we lose something or someone that we love, we grieve. It's as simple as that. Loss can take many forms. The American author Judith Voice describes loss beautifully. Our loss includes not only our separations and departures from those we love, but our conscious and unconscious losses of romantic dreams, impossible expectations, illusions of freedom and power, illusions of safety, and the loss of our younger self. If we look at loss in more concrete ways, it can involve the loss of a significant person, whether it be a family member or a friend, the loss of an external object, our pets, our belongings, loss of part of ourselves through physical illness or disability, fertility, or our senses. Social status and roles can be grieved and lost. And in terms of the psyche, our self-esteem, our ideals, freedom and independence are also important areas. In the wider community, the loss of religion and culture is an important growing issue. And of course, there are developmental losses. They are invariable and inevitable part of life. For instance, the role of a child becoming an adolescent, leaving school, marriages, divorce, having children, retirement, old age. Some losses can be actual and some can be symbolic. For instance, a loss of a job, which is an actual job, actual loss, can also be accompanied by symbolic losses such as self-esteem or career aspirations. Some people might be surprised that seemingly positive life events, such as marriage or parenthood, can also contain a level of loss. For instance, the loss of freedom or the loss of sleep in the case of having children. So our developmental stages all contain a level of grief work. Bereavement refers to the fact that there's been a loss of a special person, of someone that we have a close attachment to. Grief is our internal response to loss. It's how we feel it emotionally, how we process it cognitively, our physical responses to loss and our behavioural responses. And mourning is more the external expression of our grief. How we mourn is informed by our culture and social systems. Some mourning rituals are done privately, whilst others are done as a community. Rituals such as attending a funeral, a wake, memorial services, sorry business, wearing black or white attire, sharing a prayer, singing, dancing rituals. These are all very important in mourning. It's interesting that some of these ancient cultural practices have continued, whilst others have been banished, only to resurge again. For instance, the Gaelic cultural practice of keening involved women or highly respected community members chanting sounds, screeches, as well as improvised verses about the deceased life and their deeds, and was often accompanied by body movements like rocking and beating the chest. From my point of view, I can really appreciate how these kind of rituals can be therapeutic in allowing a form of physical release from the pain, helping regulate our emotions and bypassing words when words are just not enough sometimes. Dr. Elizabeth Kubler-Ross was an American psychiatrist and considered a pioneer in grief research and palliative care. From her work with patients with terminal illnesses, she described 5 stages of grief, and some of you might be quite familiar with these. Denial, anger, bargaining, depression, and acceptance. Denial is essentially the very first often confronted reality. It's that sense of shock, feeling numb, our difficulty in refusing to believe that the loss has really occurred. It's a defense mechanism that we use to protect our psyche from being overwhelmed. And then as the shock fades, the pain surfaces, and often it's expressed in anger and resentment. And the anger can be directed towards ourselves, towards doctors or caregivers, towards family, friends, or even the deceased. Bargaining is another defense mechanism that we use in order to gain control. We start fantasizing about the what ifs and if only. It's a form of magical thinking when we bargain with higher power or the universe to undo our loss. For instance, I'll become a better person if my loved one returns, or my pain ends. Or if only I had done some specific thing, my loved one would still be here today. And then there's depression. This is when we connect with the sadness and the realization of the finality of the loss. Now, with acceptance, sometimes this stage is misinterpreted. People often think acceptance means that we're okay with the loss. Mostly, people are not really okay with the loss. It's just that we have accepted the loss and we find ways to move forwards. However, there is no linear path, and we don't all have to go through all these stages. There's no formula for grief. People can skip steps or repeat them in a loop. Also, these painful emotions can be separated by periods of peace, calm, relief, love, joy, and that's all healthy. Some of us may not have experienced such an emotional roller coaster, but these better periods are a good sign of adaptive long-term outcomes. David Kessler worked with Elizabeth Kubler-Ross after she suffered a number of strokes and was paralysed. The two of them wrote a book together, Two Experts on Death and Dying. Over a decade later, David experienced the death of his 21-year-old son, and this prompted him to expand on her work by adding a sixth stage to grief, the importance of meaning in grief. Only the individual can find or create meaning. It's not about trying to understand the loss or rationalize it, but what you do with your grief. It takes months or years to develop. Meaning is made through relationships, through rituals, memory, and narrative integration. Meaning can take the form of creating ways to honour our loved ones, such as setting up a foundation or continuing with projects, supporting others who are in pain, living in a way that honours the loved one's values, reconsidering our own values, and sharing stories or memories. Bonanno was another important researcher in grief. He is a professor of clinical psychology who conducted 2 decades of research of bereaved individuals and provided more insights into the process of grief. He identified 4 categories of disrupted functioning during grief: cognitive disorganization, dysphoric emotions, health deficits, and disruptions in social and occupational functioning. Cognitive disorganization basically describes the sense of confusion, preoccupation with memories of the deceased, difficulty accepting the reality, a sense of derealization, as if the world is not quite real, difficulties concentrating, making decisions, changes in identity, the bereaved individuals describing part of themselves missing, or adopting personality features of the deceased. Dysphoric emotions are the ones that we know well, all too well, that of sadness, irritability, fear, guilt, loneliness, emptiness, shame. Importantly, Bonanno also recognised the link in health outcomes in bereaved individuals. Grief is acute stress which affects all organ systems. So we know that bereaved individuals often have increased doctor visits. They report palpitations, shortness of breath, chest tightness, poor appetite, fatigue, insomnia, restlessness, high incidence of heart problems, what's been referred to the broken heart syndrome. This risk is highest in the 6 months post-bereavement and improves over time. And of course, there's disrupted social and occupational roles. So often bereaved individuals withdraw socially. They report greater difficulty at work and with parenting. His research was important as it identified that resilience is the most common response to grief. Resilient people struggle initially. They do feel the pain and use internal and external resources to help support their distress, and they're able to maintain relatively stable levels of functioning. For instance, working, parenting, and they can have capacity to have positive emotions. Outside of the resilient outcome, Banana also described 3 other outcomes. The first one being that those with moderate or high levels of stress, for instance, those who actually develop depression or PTSD, but they subsequently recover. Then there's about 10% of people who develop what's called prolonged grief disorder. And then there's a delayed grief reaction, when individuals appear to function normally initially and may not initially show any overt signs of grief, but later develop intense distress. This is a grief jar metaphor that I personally like, and I think it really shows and validates grief beautifully. It was devised by Dr. Louise Tonkin, and it shows that grief doesn't shrink in time. That ball just sits there. However, our capacity, we are the jar, to contain our grief grows over time. Of course, there are going to be times where our capacity shrinks again and the pain seems quite large, and these might occur at times of anniversary reactions or other reminders. Another useful concept that I've come across is the dual process model of grief, and it shows how grief involves oscillating between 2 processes. So there's loss-oriented processes of actually sitting with the pain, mourning, looking at photos of our loved one, yearning, sitting with the sadness. And there's restoration-oriented pathways of adapting to life without our loved ones, practicing skills of learning new skills and adapting to a new identity. And the fact is that we don't do these things in tandem or linearly. We oscillate between the 2, and it normalizes that we need breaks from grief. It can be exhausting to be constantly grieving. And it also shows this ambivalence that we all have about wanting to hold on to our loved ones, hold on to our pain, but also to move on. And that's fairly universal. Moving on to the prolonged grief disorder, which previously was used interchangeably with other titles such as complicated grief or traumatic grief. And again, we have to remember that this only happens in a minority of bereaved, around 10%. And it's characterised by distressing symptoms that continue for at least 12 months following the loss of a close attachment. For children, we have a lower threshold, so we would use 6 months as the cutoff. And it's characterised either by intense yearning or longing to be with the deceased, intense preoccupation with thoughts and memories of the deceased, and various other criteria. So again, for those who are interested, DSM specifically specifies 3 out of 8 criteria. So things like feeling as though part of ourself has died, a sense of disbelief about the death, avoidance of reminders that the person has died, often coupled with intense searching for things that remind the person of the deceased one. Intense emotional pain, difficulty reintegrating into life, numbness, feeling that life is meaningless, and intense loneliness as a result of the death. Some people perceive grief as frightening, shameful, and they also worry that if their grief lessens, their bond with their loved one ends. Some people believe that by enjoying life, they're betraying their lost ones. And that's really important. So who develops prolonged grief disorder? The way that we look at this is we classify people and their presentation into different categories. For instance, their pre-loss risk factors. So this is what each person uniquely, the kind of risk factors they bring into the equation. So we know that being female, being older, from a lower socioeconomic status, and having a close relationship to the person who's died increases your risk. In particular, a romantic partner or a death of a child are particularly painful. And of course, pre-existing history of mental health conditions such as mood or anxiety disorders increases our risk, and so does childhood adversity and multiple losses. The loss-related factors which increase prolonged grief relate to the death being sudden or unexpected, being violent, accidents or suicides. And of course, post-loss factors, which increase the individual's risk of developing a prolonged grief disorder or lack of social support. Prolonged grief disorder is a serious condition. It causes personal distress and suffering, and it interferes with functioning. It's associated with long-term adverse physical ill health, such as heart conditions, autoimmune conditions and cancers, as well as psychological outcomes because of the prolonged nature of stress response in the body. 75% of people have comorbid psychiatric conditions such as major depression, PTSD and anxiety, as well as alcohol and substance use. Professional support is indicated in this group, and effective treatment include therapy, which is coming to terms with the loss, accepting the reality, and changing the relationship with the deceased internally, reducing avoidance, re-narrating our lives, and strategies to manage the intense emotions. And of course, looking at ways of restoring that person's ongoing satisfaction in life, in re-engaging in activities, goal setting, thinking about the future, and reconnecting with others. There's most likely going to be a role for medications to help reduce anxiety, improve mood or sleep, and of course addressing substance use if it's indicated. Major depression is another condition seen in bereaved. The DSM-5 classification of major depression involves a diminished or irritable mood and or decreased interest or pleasure in activities, as well as other associated symptoms, such as feelings of guilt or worthlessness, loss of energy, difficulties with concentration, thoughts about death and suicidal ideations, changes in appetite and weight, psychomotor retardation, as in motor restlessness or slowing, and difficulties with sleep. For the diagnosis of major depression, we're talking about this pervasive sense of low mood that's there daily for at least 2 weeks, and it's causing significant personal distress and functional impairment. Grief and major depression do look similar. They may even co-occur, but there are some differences. The sadness, crying, depression, of course, can be seen in both. However, in major depression, the depressed mood is more pervasive. It's across all contexts, and there's an inability to anticipate happiness or pleasure. However, in grief, there's pangs of pain. It comes and goes because of either internal reminders or external reminders of the deceased. But people who are grieving can generally also have positive emotions, and the humour is preserved. The content of thoughts in major depression are focused on negative thoughts about the self, about the world, about the others. There's this persistent self-loathing and negativity. Whereas in grief, the preoccupation is mainly with memories of the deceased, and self-esteem is preserved. And avoidance is another different pattern. So in major depression, avoidance consists of general social withdrawal, low motivation, loss of enjoyment in pretty much everything. Whereas in grief, avoidance is limited to reminders of their loved ones and their loss. Treatment of depression in this context includes a personalised approach with a combination of medications and therapy. Whilst the focus of my talk has been on bereavement grief, I want to briefly mention a couple of other important areas of grief that are not so well recognised. Ambiguous loss. There are complicated life situations where we might be unclear if loss has really happened or it has not. Is the loss permanent or temporary? The person might be here physically, but they're not there mentally. For instance, in the case of a loved one with dementia or severe addiction or severe mental illnesses, or in the case of a missing person, it's a limbo. It's very painful. It's very difficult to get closure, and it can really complicate the grieving process. The term disenfranchised grief is grief that is not openly acknowledged, socially validated, or publicly mourned. Examples include suicide. There's been a taboo of suicide historically in our culture, and unfortunately, it still continues. Unfortunately, it leaves those bereaved by suicide feeling quite marginalised and isolated. Women who've had miscarriages or terminations were not previously recognised as legitimate grievers. Young children and people with intellectual disability can also be often overlooked. In addition, death of other important relationships, such as death of a teacher, death of mentors or ex-spouse or a pet, can be considered disenfranchised grief. Migrants, so again, despite their wish to migrate to improve their quality of life, they're not allowed to tell their stories of the old country and grief in their resettlement. And older people losing their independence, freedom, or self-esteem, again, face a level of disenfranchised grief. I also just want to talk briefly about how grief presents in people with autism. It's not well researched, but it's increasingly identified, and it's an important area to consider. The following areas have been noted to be specific challenges for people with autism, that because of their delayed emotional responses, bereaved individuals might appear unaffected at first. People with autism often feel emotions more intensely, but they have difficulties identifying their emotions and communicating them, a term called alexithymia. In addition, difficulties with their emotional regulation means that sometimes it comes across as having meltdowns or just becoming increasingly socially withdrawn. Grief can result in increased sensory sensitivity and increased repetitive behaviours or stimming. And difficulties with focus, organisation are also commonly reported. And people on the autism spectrum can also become very hyperfixated or ruminative with their deceased, and they have difficulty integrating it into their life history. They are going to be at a higher risk of developing prolonged grief disorders and anxiety and mood disorders. And it's really important to recognise that and to use clear language to describe what is going on for that individual. Trying to avoid ambiguity, validate their distress. It's important to allow time, and you might need to be repeating over and over again in different language what has happened. And each time the person may only be able to have limited capacity to absorb or process a certain amount of information. And of course, structured rituals are really important for the grief process. Grief has also been a huge catalyst for works of music, poetry, art, and literature. It's not surprising that the majority of artists and authors who have used this medium as a means of processing their own loss and memorialising their loved ones. My opening slide was called The Angel of Grief, and it was a work by William Story in 1894. He made the sculpture for the grave of his wife, and that was his way of memorialising her. Art can be a universal language of connection. It allows processing, sometimes non-verbally. This sculpture is called Melancholy. It's by a Romanian artist who created to represent the empty feeling of sorrow following the loss of a loved one after the artist himself lost his wife. As the Persian poet Rumi reminds us, the wound is where the light enters us. Many people turn to the world of art and literature to connect with their pain. They can gain comfort from a shared understanding. There's resonance, but people also use art and creativity to help with their own grief journey. So in terms of supports, obviously there are lots of community supports out there who provide both individual as well as group counselling sessions. Our general practitioners are always a good starting point as well, and they can also either provide us with grief support, review the need for medications, but they can also refer on, using services such as a mental health care plan to access psychology or other specialist services. My two favourite bits of work. One is this book, which is really easy to read, and it's a very comprehensive book about all aspects of grief, written by Zita Annette Weber. And more recently, I've come across this little brochure which you can actually download, and it was only published last year. It's called This is Grief. Again, it's there right at the end. It's a gentle guide for individuals and families, and it was essentially commissioned by Palliative Care in Tasmania. And it's just a beautiful book that, again, I think would also appeal to younger children because it's really very simplistically laid out with beautiful pictures. So in closing, I want to reiterate that grief is a psychological necessity. It can also be very painful work and looks different in each of us. We need to approach our grief with an open heart, accept the loss, feel it, and deal with the pain. We must adjust to a world without the deceased and find an enduring connection to them and find meaning in our lives. The cure for grief is to grieve. It's an active process and requires ability to adapt coping strategies to changing circumstances. The pain stays with us, but our capacity grows around it. Remember the grief jar analogy. There are going to be anniversary times where grief becomes reactivated again, and we have to swim over those waves of grief again. Encouragingly, resilience is the most common outcome. As a community, we can aspire to provide safe, reflective spaces to discuss grief and role model it across the wide spectrum of presentations. For those who are suffering with prolonged grief or depression or other forms of high distress, supports are available and recovery is possible. By talking about grief, reading about it and seeking support, we can integrate grief into our life history. For most of us, grief rewards us with deeper insights of ourselves and new perspectives of life, relationships and spirituality. I want to leave you with this last lovely quote from Elizabeth Kubler-Ross. She says, "The most beautiful people we have known are those who have known defeat, known suffering, known struggle, known loss, and have found their way out of the depths of this. These people have an appreciation, a sensitivity, an understanding of life that fills them with compassion, gentleness, and a deep loving concern. Beautiful people do not just happen." And that's the end of my presentation. Thank you.
Thank you very much, Mojdeh, for that very in-depth and comprehensive presentation. I'm sure you would agree there was so much useful information in there, and thankfully it's all been recorded, so you can go and on YouTube or Baha'i blog and watch this presentation again. Thank you very much.